show you. I just want to show you because a number of people who are new are not aware of the link which I share. So this is our YouTube channel, and you will find the playlists. Okay, if you will just go through the playlist, you will find all the topics which are being we have discussed before. Okay, my basic aim is not to make you just following me like just without any sense. I want you people to interact and understand that I am not giving you a spoon feeding. So you can mute. Very disturbing. Please, I request all of you to mute yourself. Dr. Nasir, please make sure you don't unmute. Okay. Okay. So these are all all the playlists, and my aim is just to give you a guideline that these are the important points, and then it's up to you from whatever source you want to read. Of course, I always suggest and recommend that articles are the best source. So if you want to just go to this link, okay, so you will find one folder for articles, one folder for books. This is FRCA mind maps. This is question wise topic wise questions, and this is some scenarios and everything. So if you want to see any topic, there are a number of options you can do. You can just write any topic, and either with the abbreviation or with the topic you will find it. If you don't find it, you just have a look here. It's for gynae, peds and elderly. It's for cardiac, respiratory, thoracic, neuro, endocrine, muscle. You if you just spend few minutes, you will be able to find out where are different things. So it just need your attention. These are updates in anesthesia. Okay, so every year this usually an update comes when the latest I think 2019, if I'm not wrong. Okay, so like this is for specifically for gynae ops. It was for gynae ops. This was specifically for pediatric anesthesia. This is although very old, but it is excellent for ICU. I still suggest that whosoever wants to, because you will be happy if you will find page number 1 to 200, then you will be very happy that I'm telling you a source. So it is actually majority of the topic except for some guidelines. This is very good. Okay. So we will just start our topic shortly. So just stay tuned. Okay, so this is for all articles. This is one thing, and other thing, these are books. Okay, so if you want to just find any books, you just have to open this folder. Then this is review books for basic sciences. This is review books for clinical sciences. These are ICU books. This folder is for MCQs, and if you open it, you will find uh, all in arranged. And then people ask, sir, there are so many books, which should we read? You just go to whatever source, whatever sort of MCQs you want to read, and then you go to the folder. So these are clinical sciences, either true false or choose the best. You can choose anyone, because all these books are practice. They write it practice. These are not textbooks. These, there is no guarantee that you will find questions from this book. Sometimes it seems like, because a number of examiners, they take this question and a little bit of trimming, and they make their own question. This is, unfortunately, it happens. Okay, so you will feel as if it is a question like you read, but don't try to guess that it is the same question, because you read so many questions. Sometimes it can be. Okay, it's very unfortunate. I'm listening, saying loud and clear, if it's very unfortunate if someone copy paste questions from any book. This is unfortunate if any examiner is doing like that. Okay, this is a very new book. I just actually purchased online. Okay, and it's here. So it's, you can see it is just latest one. Okay, so you can read a book, and then you can compare it, and you just know, don't need to cram each and every line. Okay, you just need to have the answers, and whatever thing you memorize, you can note it down to your main book. Okay, so that it is because a number of people say that, sir, how to revise them. No, you don't need to keep everything in your pocket. You, for example, if you find something nice, you just note it down and put it in your book, and then you don't need to repeat it again. Okay, So but it is better if you read multiple books, because it will give you a wide vision of different topics. Okay, so these are for clinical sciences MCQs. Okay, and this is for basic sciences. So I just numbered them roughly. There is no you can choose any book, preferably if you choose the book which is printed early, lately, in recent years it will be better. But actually even older books for basic sciences doesn't change much. Basic sciences remain the same. Yes, clinical sciences, never ever trust anything related to management from any of the book. Remember one thing. Okay, so this is for basic sciences. Okay, you can choose any one of the source, and then when you finish it you can go to the second one and third one and so on, as much as you will do, as much as your concept will be cleared. Okay, so this is an specifically regional anesthesia. This is excellent book here, this master pass. Okay, if you just exclude number of different approaches for a single block which are there in this book, other than that this is an excellent book, not only for regional anesthesia, it is very good for analgesics, it is very good for different aspects of regional anesthesia in variety of patients like pregnant patient. It has very good concept about ultrasound nerve stimulator. So I will just repeat only because this was written a little old, so you will not find much of ultrasound in this book. Okay, for ultrasound, actually this is a book in which you will find some of the facts related to ultrasound. Okay, so actually this was, I had hard copy, so it's not a very good print, but actually I scanned the whole book. Okay, I scanned the whole book for you people. My effort will be futile if you don't open the folder and read it. Okay, because I'm not getting any pennies for it. I repeat again and again, just to make you realize that you have to see this link. If you will not open the link, and you will always be dependent on me, if you message me I will reply to you 1000 times, but please try to learn how to use these sources. Okay, so this was a message I just wanted to share with all of you. And still if you have any doubt, I will be very happy to answer. Don't be afraid, don't be hesitant to ask me. Okay, so just last thing, this is actually before, because before doing this Zoom classes I used to prepare these questions. Okay, so since I have started Zoom, unfortunately I don't get time to prepare these files. So actually if you want to read them, you will find the chunk of the knowledge which you should be knowing for any topic. So a number of topics I have probed. The people who have the pattern of SAQs, still there will be, these are SAQs folder wise, topic wise it is arranged. They are actually old ones and need to be updated. Unfortunately I couldn't update them, but still you will find a lot of knowledge. Even the people who have MCQs, I will suggest you to have a look and see whether you know the answer of the question being written here or not. Again I repeat, you should be knowing the questions which are being discussed here, and you can find the answer from any source. Okay, so this is for especially to the people who have still have written exam, because even in some part of the world, in India, even in Pakistan, is MSMD program still have written part. And all of you, I will suggest you, whosoever wants to do Irish fellowship exam, it's still written. I repeat, still written. It has SAQs. So please just keep yourself intact with these pattern, because if you suddenly open for FCI, that you will be in trouble. But if you are in touch with this, you will have no problem at all. It will be just like you are already prepared. Okay, so this is FRCA mind map. Okay, and if you are able to make mind maps for you all topics for yourself, that is the best source how you should be revising and making notes for yourself. It's difficult, but if you are able to do it, it will be the best thing, because in FRCA mind map not all topics are covered, but a number of topics, whatever topic you find, do have a look at it. It will be easier for you to understand that topic. Okay, and this has some viva scenarios. Again, and I am unable to update them because you see here in from up this these are old FRCA questions. I used to compile them. Unfortunately, lately I am unable to update them. Okay, and these are FRC from website. I have downloaded all of them. Okay, if someone can help me in updating it, I will be obliged. Okay. Anyways, so this is all about it, and this this folder also I share daily. This is actually about year wise. Okay, that folder is topic wise, and this folder is year wise. So you will, if you will open it, you will find three sources. One is BJ education, one is anesthesia tutorial of the week, and this is actually I recently had this subscription, and almost to date all articles are arranged. So just have a look on this. This is made by me, and I'm again saying, I'm not saying like a puppo or like a sister-in-law or like a mother-in-law that you see I have done it for you, but it's very depressing for me that none of you see it. I can guarantee you that majority of the people who are listening have not have a look had a look at it. So this is disappointing for me. Like my effort is useless if you don't have a look at it. This month, unfortunately, August one, I did not download it, but you will find all the topic. You can go year wise. Okay, so this is my request to please have a look, and I share this folder daily. If you can just star this message, you will be able to find any article anytime. You can just star the link, like the link which is there in the WhatsApp. You just make it star. Okay, so if you want, like for example, this message you want to star, you just select it. I think that's how. From mobile it's very easy. You see, it's a star message. Yes, it's here. Okay, star message. So now whenever you want to see this message, you will just come here, and just a second, here you will find star messages. Okay, and star messages you will find this message. So this is very easy, it's very simple. It will take few minutes for you to this thing, and all the time it will be there in the star messages. So this is my request, please use this. May I am not getting any. If you don't look at it, I it's not, I have no loss. But if you all of you are familiar to it and using it and sharing it to others and helping me even, uh, I will be very happy and I will be thankful to all of you. Okay, so this time I just utilized to explain all these facts to you, so that you can get the help. Okay, so now we will go to the topic what we have to discuss today. So first of all, uh, just I want to ask you that if you want to have a discussion like the concept of this awake fiber optic, what challenges would do you think you will have? Yes, Atik bhai, like for awake fiber optic, what things you should be reacting, or anyone? If Zishan, you want to speak out?
So first of all, patient should be conscious and cooperative.
No, no. I will repeat my question. What are the challenges you will face when you are doing awake intubation or awake fiber optic?
Can I say something, sir?
Yes.
You should have a good knowledge about Fibreoptic intubation technique, good skill, and good assistant
Skill, assistance, anything else?
knowledge.
Okay. What else?
And you should have a fair idea about the. Obviously, you have seen the airway and you have decided that it is in difficult intubation. And then you have to explain this procedure to the patient.
So now you need patient cooperation.
Sure.
Okay. So the in other word, patient cooperation is very important in this procedure. This is one thing. Then you are facing problems related to gag. Okay, so patient can gag. So this is things, so problems related to secretions. Okay, and this is a question to House. Would you like to have anxiolysis, or should you do some anxiolysis for awake fiber optic or no? Or can you do it or no?
Yes, sir.
Yes, sir, we can do.
Okay, so what can be the problems if you are giving some anxiolysis?
It depends upon the sir. It depends upon the for what we are doing the fiber optic. If we are doing a fiber optic for the sorry, a huge mass in the neck, sir, then it is not advisable.
Like whatever patient, for whatever patient you are doing it, you as any sort of anxiolysis which can compromise the airway, you will not do. Okay, so this is the important thing, that you can have a little bit of anxiolysis, but you should not compromise the airway. Okay, so this is important thing. So and at any point of time, because you have to protect the instrument, the equipment. Okay, because if you don't have this airway, this bite block, uh, patient can very easily bite your very expensive fiber optic. Okay, because its fibers are very sensitive. Now in Saudi Arabia, we have disposable actually. These are actually LED, not fiber. So they are actually in a different era now. So they have this. It works like a fiber optic, but it is not actually fiber optic. In the not the true, these fibers which are very sensitive. So because if it is twisted, it will break. So whenever you are doing it, the challenges you will have, that you have to explain the procedure. You need patient cooperation, otherwise you cannot do it. You can use some antisalagogue to decrease the secretions, because it will ease your procedure. You need a very good airway analgesia. Okay, if you anesthetize and control the gag, so you will have ease. Okay, so you will have two options. Either you can go nasal, or you can go oral. Okay, so now we will go towards the theoretical part, that what are the nerves you want to block. I'm going in a I'm just going this one objectively. What nerves you need to block?
Recurrent laryngeal nerve and superior laryngeal nerve, sir, both.
Recurrent laryngeal
First of
nerve.
all,
Yes.
Glossopharyngeal nerve has
glossopharyngeal.
Glossopharyngeal nerve. Okay. If you this the question will be also bad, that whether you want to do nose, nasal, or oral, which is better, by the way.
Oral.
sir nasal. Nasal.
Okay, if there is no contraindication, you will be avoiding the bite, the bite related problem. So if there is no contraindication, nasal may have some superiority, but actually you can do either way. If you have bite block, I think there is some ease because of the angle. If you are going nasal, it may be going a little easier. I'm not sure about, because I don't have much experience of this fiber optic, awake fiber optic intubation, so I cannot comment. Maybe who have done so many times, they can comment. But you need, anyways, the questions they can ask you are about what part of nerves, which nerves you need to block. So if you are talking about nasal, so you can say that you have to anesthetize both, not only oral cavity. You have to, if you are going nasal, you have to anesthetize the nasal cavity as well. Okay, so this is one thing. And then the nerves, which whatever will be there, you have to block them. So the main thing will be tongue, and then pharynx, and then larynx. Okay, so that's what, how you will have to do. So either you for nasal cavity, you see second division of trigeminal via sphenopalatine ganglion. Okay, and anterior ethmoidal nerve. Okay, so for that, you have different options. You can put 4% cocaine plagets. What is the advantage of putting cocaine plagets, other than anesthesia, what is the advantage?
Sir, it will
Vasoconstriction.
Yes, it will.
Where it will cause vasoconstriction of vessels and there will be a lesser chance of bleeding.
Yes, so this is one thing, and but like it is not available everywhere, and it has itself, it can cause hypertension because of its vasoconstrictive effect. Okay, so if you are using lidocaine, you might need to put some epinephrine just to decrease the vascularity. Okay.
Sir, question has been asked in the Viva, how much percentage of lidocaine will you give?
Yeah,
Multiple.
I will just come to it. Just note down your questions. I have to tell this thing. Okay, I will just explain to you in detail. So first of all, nerve supply, and then how to do nose. Then the other nerves, this glossopharyngeal nerve, and then superior laryngeal nerve, internal laryngeal nerve branch, and then recurrent laryngeal nerve. Okay, so the techniques are either by individual nerve block, okay, or by doing the gargles and spray as you go. So when you this question is being asked to you, you can answer that we will have the gargles or lidocaine nebulization and lidocaine spray to anesthetize journal, like all you will be anesthetizing it, and then the later on you are going spray as you go, and another block you will be needing, it will be transtracheal to block the recurrent laryngeal nerve. Okay, so and then they can ask you about individual nerve. Before going to individual nerve, I will answer this question asked by Dr. Atik. So just tell me, Atik bhai, you have to answer please. And if anyone wants to talk, speak out, please just raise the hand. So it is easier for me to give chance to everyone. All of you are welcome. Just raise the hand. If you have any answer or any comment, just raise the hand. Atik bhai, do answer this thing. Lidocaine, how much is dose you can give in oral analgesia, this for awake?
Sir, wait, sir, 10% lidocaine is written in the book, but when they
So
have given the
I'm sorry,
answer about the 10%.
Atik bhai, I'm sorry, I will repeat my question. How much is the maximum? We are not talking about percentage. Percentage, you can make any percentage. Okay. First, my first question is that usually its dose is around 3 to 5 or 5 to 7. Okay. So which dose will you choose if you are
Sir,
discussing about oral analgesia?
if it is with the adrenaline, then it is 5 to 7, sir.
No, actually answer both of them is
No,
wrong.
sir. In topical, I think it's 7 milligram without
No,
adrenaline.
no. Just Ishan, let him talk, please. It is around 9 to 10 milligram per kg. Okay, I will show you the source as well. Up to 9 milligram per kg, because the theory is that it's not all of is not being absorbed, and even after gargles or they are spitting it out. Okay, so the dose is up to 9 milligram per kg. Dr. Nasir, I humbly request you, please mute yourself. Okay, it's very distracting and very irritating to me. Thank you. Okay, so the dose is now up to 9 milligram per kg. Okay, so they make clear this thing, 9 milligram. And now how to calculate it? We have either 4% spray or 10% spray. Okay, so Atik bhai, what does it mean by 10%? And what does it mean by 4%? Yes.
10% mean the concentration is bit higher, and the
No, how much?
and
How much it is? How many milli?
uh,
Because, for example, it is 9 milligram per kg and you have a 70 kg, so it is 630 milligram. Okay.
sir,
So how will you take to make it simple? I'm just making it 700. Okay. I'm just to make it because 700 calculation is easier to explain. So how many mLs will you take?
of
Anyone?
10%,
700.
Just a second. Okay. Just anyone who knows it, just raise the hand, please. Zishan, you want to tell?
Yes, sir.
Okay.
Sir, it's simple. The 4% means there is 40 milligram per ml,
Okay.
and
So
in
10%
10%
means,
means it's 100
so
milligram per ml.
any percentage, this is for message for juniors, any everyone, whatever percentage written, you multiply by it 10, that will be milligram per ml. Like if you have 0.1%, it means it is 1 milligram per ml. If you have 0.25%, it is 2.5 milligram per ml. Okay, clear? So it's like that. So 10% means 100 milligram per ml. Now comes, now we said that we want 7, we can give up to 700 milligram. Okay, so now you have 10%, so it means it is 100 milligram per ml. Am I right? So you can have up to 7 ml, but you have a spray. So how will you make sure that you are putting 7 ml? What is the answer for it, this question? Anyone, please?
Sorry, I lost the question, sir.
7 ml. Okay, according to
Yes,
this
sir.
calculation, we can have 10% up to 7 ml. Okay,
Yes, sir.
so but how will you calculate this? Because we have a spray.
Sir, there's a formula. How many?
Actually, the answer is that it is depending on the manufacturer. Okay, this is, there is no fix, but usually 1 ml is equal to 10 puffs. Okay, so if you calculate by this, like one puff is 10 milligram. Okay, so if you want to have up to 700 milligram, you can have 70 puffs if this is 10%. Okay, if it is 4%, accordingly it will be 40 milligram per ml, so one puff will be 4 milligram. Okay, so if you
Sir,
want to
please
have
repeat this.
okay, I will repeat. We told that the dose require allowable is up to 10, and just to make it simplify I've made it 10. So 10 multiplied by 70 means 700 milligram. You the safe the allowable dose is around 700 milligram. Okay, so you have 10% spray, which is 100 milligram per ml, or you have 4% spray, which is 40 milligram per ml. Okay, so now you we want to calculate that how much puffs you can do with the spray. So actually it depends on different the manufacturers, but usually 10 puff is equal to 1 ml. Okay, so if you give 10 puff, it will be 1 ml, and we calculate that if you want to give 100 milligram per ml, so it will be 7 ml for 700. So 7 ml means you can have up to 70 puffs of 10%. Okay, or if it is, for example, 4%, so accordingly you can have more, but you never need, actually you never need that much. This is just to understand, because not everything is absorbed. Okay, so you are doing the gargles and patient is throwing it out, doing patient is doing gargles, and the best way is that you explain the patient don't to drink it, it's not a Pepsi. Ask the patient to gargle it and throw it out. Gargle it strongly, and then throw it out. So this is how you will get the adequate, and it needs some time, 5 to 10 minutes at least. You need to gargle strongly to make the area ready for
Sir,
intubation.
isn't it swish and swallow?
Swish and swallow.
Because the oropharynx and
Actually,
the other
actually, I
parts.
don't know. Zishan, actually, there is no need to swallow, na? So it is better if the patient is taking it, I don't know what happens in the gut for lidocaine. I'm not sure about it, but I don't
In
think
upper
so. It
GI
will be.
endoscopy, I've seen that the swish and swallow.
No, no, you are
The
right.
nothing
You are
happens.
absolutely right. But actually, logically, you don't need to swallow for awake
Hmm.
fiber optic, because we are talking about awake fiber optic. Okay.
Right.
Maybe they are, if they are doing it, maybe it is anesthetizing the stomach as well. Maybe I'm not sure about it. Okay. So, but for awake fiber optic, you no need to swallow, because it will be wasted, and actually, I'm not sure about it. So this question is a remain unanswered for me. If someone can check it out, what happen if you ingest lidocaine? I don't think so. It is absorbed from the gut or things like that. I don't think so. Okay, so anyways, this is the concept which you need to know. For who asked the question, to repeat? Are you clear now? The person who asked the question, are you clear, brother?
Yes, clear, sir.
Okay, thank you. So this is the concept for it, and then associated medication. I'm sorry. Okay, so anti-salagogue, I told you that you can have some glycopyrrolate or hyoscine. Okay, atropine. Usually, hyoscine is not available frequently in IV, but you can use glycopyrrolate or atropine. Okay, I'm not wasting time for individual nerve blocks. You can have a look. It's only according to the anatomy. So I'm not wasting time because it's very clear. So what you should be knowing that which branches are supplying. So internal branch above the level of vocal cords. It's internal branch of superior laryngeal nerve, which is branch of vagus nerve. So they will ask you, and below the level of vocal cords, it's recurrent laryngeal nerve. Okay, so this is individual block you can, and this one for, as I told you, that you might need this translaryngeal or transtracheal. They identify the cricothyroid membrane and they inject through it, and the patient is asked to cough and it is spread. This it's being done like that. Okay, so the other aspects, as I told you, that they can ask you about the indications. So of course, you are predicting for difficult mask ventilation, difficult tracheal intubation, and then you just a second, not here, I think. As I told you, that you can have a sedation, but the problem is that you should not over sedate the patient, which cause airway obstruction, respiratory depression, apnea. Okay, so you can use the medication in a way according, there is no fixed rule. You have to avoid apnea or avoid this one, respiratory depression. So dexmedetomidine is a good option because it does not cause respiratory depression. Okay, they have written here propofol and remifentanil. I would never advise you to tell unless fully, because that's the tricky thing, to use any source. Because if you read this article and very happy that in the exam you are telling this thing, the examiner will catch you. Okay, no, don't try to uh, uh, reproduce everything you read, because the basic thing you will stress that we can use it according to the scenario, but at any cost we should not over sedate the patient, which result in airway obstruction, and the whole purpose is finished. Okay, so that's the basic thing we should be knowing. So actually I opened a very nice source here. Where is it? These are the things which actually I told you just here. They, I just saw here the dose as well, because sometimes the things which is in your mind remain in your mind. I will share.
Excuse me, sir.
Yes.
Sir, the book you have shared with us for the airway,
Mm-hmm.
current, sir, we haven't found in your folder.
I did not share it so that you will ask me at least. Oh, actually,
Okay.
this document I just found. Okay, I just found this document, so I will update. Remember one thing, Atik, I am doing it all alone. And just think, just for a second instance, just think about me. How much I disappoint myself. I'm how much I am disappointed by you people if you people don't respond. Okay, so I will do it. Don't worry, I will do it. So they have just give you some ergonomics, that anesthesia machine, suction, and this and that, and video monitor, airway trolley assistant. They just made mimic the situation for you. Okay, oxygenation, airway topicalization, lidocaine. I will send it to you, and you will just have a look. Okay, They have written, you see, target control infusion remifentanil, but because I have used remifentanil and I tell you that remifentanil sometimes cause apnea. Okay, so this is a tricky answer. That's why you see this is nanogram per ml. You cannot do it ever in your life in Pakistan without this TACI pumps. Okay, so you will only use this Minto model for remifentanil. The people who are aware of this topic, I will, because this is future and this will be asked in your exam, this target control infusion and TIVA we will discuss inshallah, hopefully in our near future. I was just thinking to make one discussion for inhalational induction with all the related clinical things, and one for IV anesthetic with all the related things. Okay, so this is, if you read it, this is, I just explained to you, this is target control infusion, and there is one Minto model. So they are telling you this thing. So that, and please just remember one thing, you don't need to reproduce each and every line of the paper you read. You just have to extract what you can reproduce. Okay, what else? You see, this is the source, recommendation 9 milligram per kg. Okay, the dose of topical lidocaine should not exceed 9 milligram per kg. Okay, so you will be surprised. How many people have done awake fiber optic? Just please raise the hand if anyone has done it.
I've seen it
How many times?
2 times.
Yes, Atik bhai. Any one of you? Dr. Dora, yes, I would be very happy to listen something from you. Dr. Dora, how many times you have done or seen awake fiber optic?
None.
Very good. You are very, that's the beauty. I will online, I will accept this thing. I have never in my 18 years career, I have never done awake fiber optic, and I have no regret. I am very happy that I never face a scenario in which I need to do awake fiber optic. But in the exam, you are selling it as if it is the talk of the day. So in the exam, you have to tell, wherever, because remember one thing. This is the backup. In difficult airway, your answer is not completed till the time you don't tell about awake fiber optic. You don't tell about the nerve blocks for the how to topicalize the condition for awake fiber optic, until the time you don't tell that we will be ready for tracheostomy, and you pray all the time that you never ever face this scenario. Okay, but in the exam, till the time you don't tell about awake fiber optic, and till the time you don't tell that I have a backup for tracheostomy, you will never pass. And remember one thing, this is one of the blunders. If you don't tell in the exam, the examiner will never pass you. Yes, Dr. Humera, what you are asking? Okay, so actually I will send you these sources. Remember one thing, every topic has a chunk. So if you understand the chunk of the topic, the rest of the things, actually the indications, the contraindications, of course if the patient is refusing, you cannot do it. So things like that. So I'm not I just don't try to make you cram the topics. I want to give you a concept, and after that it will be very easy for you. Okay, so there is a concept of sleep fiber optic. Can you do sleep fiber optic intubation? Sleep fiber optic, actually I have done it, but not awake fiber optic. Okay, so these are the algorithms, I think, difficult DAS algorithms. So I will share you if anything not clear, please just ask. I have just given you a concept of this topic, and inshallah I hope you will understand, and you will, if any question, you can come back to me. Okay, what is the next topic in this? So tomorrow we will have this topic. Okay, so I hope you understand, Uh, if any question, you can ask me anytime, okay? And again, I repeat that please try to trust yourself and try to find the answers, okay? So, Atik bhai, you understand? Any other question which is being asked in the written or MCQs, any confusion you want to clear?
So it was sir, fiber optic. Sir, they always ask for the fiber optic in the Viva. Mostly then asked, and sir, they mostly ask uh, about difficult intubation, sir, uh, in the dog station, sir.
Yeah, difficult intubation we will inshallah, because actually at the moment I'm just trying to just go through this book, okay? We have done 4 5 topics from this book, and I will, so actually awake fiber optic, before we finish I told you that the indications, the contraindications you can see here. Then what things, as I started with you, that you need to bribe the patient. You have to make sure patient is not fighting with you when you are doing it. So if the patient refuse, you cannot, no way in the world you can do it. So you need patient cooperation. You need controlled anxiolysis. Then you need to give some this antisalagogue, and always you should have a backup, okay? Because tell me one thing, of course it is very least likely, but the patient can have laryngospasm, okay? I'm just telling you that it's least likely that awake patient goes in laryngospasm, but you can face, okay? Patient can have the problems like this when you are doing this if you, that's why nobody does transtracheal, okay? And I will, if you are doing it at your place, I will never suggest you to do transtracheal. Don't do anything fancy, because for example if you hit it, now you have already difficult airway, you start having bleeding, what will you do? Okay, so these things are theoretical, practically believe me, things are totally different. So I will never suggest any one of you to do transtracheal unless you are very experienced, you have very clear anatomy, and you are sure that you will not start having a bleeding in the airway. Okay, so this is all.
Lidocaine nebulization would be preferred here.
Lidocaine nebulization, I have never seen, Zishan. I have never done it myself. That how much is it is effective. Okay. One other thing I have never seen in my life.
In a Farsi books I have here, sir, listen about the xylometazoline spray.
Xylometazoline. Yes, this is for vasoconstriction. Okay, this is for vasoconstriction. And another thing I was just about to tell, I forgot. It slipped out of my mind. Yes, another thing I have never seen in my life, and I don't have very good concept. What is racemic epinephrine? Has any one of you seen it? Yes, Dr. Dora, you are representing.
Sir, racemic epinephrine is when you given with the some form of distilled water when you
No,
are
no, no,
giving.
no, 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 Atik bhai. It's a specific racemic epinephrine. It's not available. It's not available in, even in Saudi Arabia. It's not available. Dr. Dora, is it available in your country?
It is available, but it is used, as far as I know, primarily pediatrics use it for inhalations.
Yes, for decrease in airway edema. Okay, but actually, Atik bhai, it's not like that. It's a mixture of R and S isomer. Okay, it has both isomers, and I think there is some difference about it. I don't have clear
I
concept.
think it has less cardiac effects.
Yes, it has less toxic effect. Yes, I, before I finish, I will just show you one thing, because I think this is just part of calculation stuff. People, screen is visible still. Yes, so I will just tell you one thing, maybe you people know about it. So I will ask if anyone knows about it, just explain to it. What do you mean? Because whenever we are having this xylocaine with epinephrine, it is written 1 ratio 200,000 or 1 ratio 100,000. What does it mean? Yes,
1
Dr.
ratio
Maruk.
200.
Just let Dr. Maruk do it. Just please.
It means 1 gram in 200,000 ml.
1 gram in 200.
1000 ml, and then 1 ratio 100,000 means 1 gram in 100,000 ml.
Okay, this is very difficult to understand. What if, how much it will be in 1 ml? Because you are not using 1 gram and this all this. You are using it in 1 ml. Okay. So how much will be in 1 ml?
So it is 1000 milligram per 200,000. So we divide by 1000 on both sides.
Just a second. Just a second. So it will be 1000 is equal to 200,000 like this ml. So you divide it
Yes.
by 1000.
No, we'll have to divide by 200,000 to get 1 ml. How many milligram in 1 ml?
So how much it will be then?
Let me calculate it. 200.
It's actually 5 microgram in 1 in
No, no,
200.
your answer is right, but how you calculate it? Actually, even I don't know. This thing that she is telling, I don't know. But I know the formula, the practical formula, how to calculate it. Okay? But I don't know this
Oh,
thing.
okay. Or
Okay?
I'm just doing the math that in 1 gram, in 200,000 ml, there's 1 gram. So you
Just a
divide
second.
by 200,000 on both
Just
sides.
just
Yeah.
a second, Dr. Maru. Just a second. Just we will
Yeah.
all be benefited. What you say? 1 gram is equal to
200,000 ml.
200,000 ml. Okay?
ml.
So it means
Yes.
1000 milligram in
Milligram.
200,000 ml. Okay? So
Yes.
it means again 1000, again 1010 in like this. Okay?
Yeah.
This is
Microgram per ml.
microgram. Okay?
Yes.
So
Yes. Yes.
now so you will divide it by this one.
You will divide by 200,000. Then you will get how much it is in 1 ml.
Very good. You see, that's how we learn. Thanks a lot, Dr. Maruk. I did not have this
No
concept.
worries at all.
So
No,
actually,
no,
I
no problem.
calculate in a very different way because somebody taught me a total cramming stuff.
Dr. Murrah, please kindly send it in the group, Anesthesia 4 knowledge group, so that we should get benefit from it.
Now,
Okay,
Atiq,
okay, I will send
it's
it.
actually very clear. I will just repeat it. We are telling that it is 1 gram in 200,000 ml. Okay, because it was 200,000. It was 1 ratio 200,000. So it has 5 zeros. Okay. So what she told, now we converted it. If we convert 1 gram into milligram, it will become 1000 milligram. Okay. This is milligram. Then the volume is the same. Then you again multiply by 3. These are 3 zeros for conversion to 1 gram to 1 milligram. Okay. Then from conversion from milligram to microgram, you will add another 3 zeros. Okay. You understand? You will multiply by 1000. So now we have this 6 zeros, 1 microgram in 200,000 mils. So you divide it by 200,000 mils. So 5 zeros will be cut and this will be remaining and this will be remaining. So it will become 5. Understand or no?
Understand, sir, understand.
Okay. So now if it is, for example, 100,000. So all calculation will remain the same. Here it will be 1. Okay. It will be 100,000. So it will become 10. So 1 in 100,000 means 10 microgram per ml, and 1 in 200,000 is 5 microgram per ml. Okay. Thanks a lot. So this is also something which not everyone knows. Dr. Maruk, thanks for teaching me. Where is
No worries at all, sir. Thank you.
Okay. Okay, so remember one thing. These things you will never find in books. And these things you will learn where if you teach to 5 people. Okay. If you teach to some of the people, you will definitely learn. So the best way to learn is to teach. Believe me, I thanks all of you that in last 1 year, as much I have cleared my concept, a number of things like this. Okay. So you understand this thing, that if you want to be sure about the things which you read, start teaching others. When you will spit out the knowledge around you, believe me, first of all you will learn. Just try to tell whatever you read last night in the morning, tell to anyone around you. Okay, and don't hesitate. Even if you tell something wrong, they will correct you if they are superior knowledge with you, or you can reconfirm it. So this is my message to all of you. Okay, so thank you. So tomorrow we will go to the next topic. All of you are requested to share whatever you learn, even for the group. Because my purpose is the betterment for all of you. Okay, like even we have a lot of sideway discussions, still we had a class for 53 minutes. Okay, and I think if you just now you go back to the topic of a fiber optic, I can guarantee you it will be very easy for you to read. Okay, so thanks a lot. So tomorrow inshallah same time we will have our next topic, this amniotic fluid embolism. Thank you very much.
Thank you, sir.